Hello, everybody, and welcome to the July episode of the Modern Medicine Podcast. How is everybody doing today? Thank you all so much for joining us here on the Modern Medicine Podcast. This is the place to be for the best and newest information in the world of healthcare and medicine. We have an absolutely terrific episode planned for you. Joining me, as always, Producer Dave. Producer Dave, what's going on, my friend?
I'm well. We're trying to stay cool in our Westwood studios here. And you might have to eat some words about the local baseball team, Dennis. I'm just saying.
I've been dreading that all month. But I'm happy to eat those words. And then, of course, I'm here with an awesome guest tonight, Dr. Michael Curran, who is the founder of Greater Boston Urology, one of the huge urology practices in the area with offices in Dedham. And we are going to talk today, Producer Dave, about prostate cancer screening, which is a huge topic, something that every man needs to be thinking about, something every man needs to be talking about with their doctor. We have some great stuff for in the news, a new way potentially to ward off depression. We're going to talk about competitive eating. We're going to talk about AI again, and we got a couple other good topics. So it should be a great episode. And then, as you mentioned, we are going to get to the Boston Sports Minute, where I got some major words to eat from last time.
Very good. I'm excited.
All right. There'll be some.
I didn't bring. Is that why you wanted me to bring 10,000 hot dogs today to the competitive eating discussion? Because I forgot.
What's going to be more, eating hot dogs or me eating words from the stuff I said about the Red Sox?
A lot of eating.
Last episode, a lot of competitive eating going on. All right. Well, let's bring in our guest, Dr. Michael Curran, the founder of Greater Boston Urology, current urologist with Sturdy Memorial Hospital, and one of the great doctors in this community in the Dedham and sort of Southwest Boston area, someone that's always there for me and all my patients. And I know I've sent you a lot of people, and you're always taking my calls and bailing me out when I have a urologic problem. So thank you for that. Welcome, Dr. Curran.
It's my pleasure to be here. Thank you very much for having me.
Awesome. So we're going to talk about prostate cancer. Before we even get into that, tell us a little bit about your practice. And you have a couple locations, right? Not just Dedham.
So my personal practice is in Dedham. I've been started in 2000 right out of residency at Norwood Hospital, and had an office in Norwood, and have practiced in this area for the last 26 years. In 2015, 2016, we merged several of the practices around southeastern Massachusetts and formed what is called Greater Boston Urology. We have offices from as far north and west as Leominster and all the way down to Hyannis on Cape Cod. We have a total of about 23 doctors in the practice. Wow. And we do almost 30% of all the urology in the Commonwealth.
Wow, that is impressive. Absolutely massive practice. I feel like that deserves a round of applause, right? Do we have a round of applause? That's amazing. Good for you. Well, you guys are great, and it's a terrific practice for individuals looking for urologists out there. And I know I've sent a lot of patients to you guys, and like I said, you have always been there for me and my patients, so totally appreciated. I wanted to bring you on today because, prostate cancer screening is such a hot topic, and it's something that every guy has to think about, but it's so confusing. It's confusing to me, so I can only imagine what it's like for patients trying to make sense of it. And my sense is that if you go to different doctors, are going to give patients different recommendations because there's so much confusion about the literature. So I want to get into all that with you. But before we even go down that road, I want to hear why prostate cancer is even an important topic for men to think about.
Well, it's the most common cancer that men will have in their lifetime. So we see around 1 in 6 men will have a high likelihood of being diagnosed with prostate cancer. If you compare that to what women deal with breast cancer, and we know how prevalent breast cancer is in women, it's 1 in 9 women. So prostate cancer affects more men than breast cancer affects women. So it's a very, very important thing that men understand. The other thing about prostate cancer is that it's, in its early stages, a silent disease. So that's why screening is such an important issue. And with changes that have happened in the management of patients with prostate cancer and with the way we do biopsies, there's been a lot of controversy about what screening should entail.
Yes, and I want to get into that, but just before we even get to that, I want to hit on one thing you just mentioned. So when I was going to ask you, what are some of the signs and symptoms of prostate cancer? But we both know that for many men, there are none.
That's right. The most common sign and symptom is nothing.
Right.
And most patients that we see that are diagnosed with prostate cancer, it's simply because of an elevated PSA. The elevated PSA is going to outpace any type of actual physical symptom or sign that you'll pick up on physical exam. For example, the digital rectal exam that we do to palpate a man's prostate. If we feel a cancerous nodule, their PSA probably elevated 7 years prior to that.
Right.
So the testing we can do is a little bit of a time machine. It can move things up. The common symptoms that are associated with prostate cancer will be voiding dysfunction, having frequent urination, urgent urination, and then sometimes bone pain is even mentioned as a symptom. But these symptoms occur with late-stage disease. Many times, if you are having those symptoms, we may not be able to cure your cancer. We likely could manage it, but we may not be able to offer you a cure.
Right. And it's funny because when I went to medical school, they talked about something called old man's disease, which is really urinary urgency, waking up at night to pee. So when you say that the symptom of prostate cancer, when there is one, is urinary urgency, that's a very common and often benign symptom. It's often a sign of an enlarged prostate, which is a harmless, generally condition that just causes that sort of dysuria or urinary dysfunction. So it becomes, I think, there's no real hard and fast clinical rule to distinguish between what's prostate cancer and what might be just, say, a benign prostate enlargement.
Yeah, the only way you're going to know absolutely for sure is to do more advanced testing.
Like a blood test.
Like a blood test of a PSA. I still believe in the physical exam. I think it's important that the prostate should be examined. We're seeing less and less of that occurring for reasons I don't quite understand, but that's what we're seeing. And with imaging and advancements in imaging, there's other types of screening we can offer to patients.
That's really great. Let's talk a little bit about prostate antigen testing for prostate cancer screening, because this is actually one of the more interesting and controversial areas in the field of medicine. And just to give, people that might not be medically trained a little background, this is a simple blood test that can pretty much be done at any lab or any doctor's office. You get result back in a day. It's a really easy test to do. And it's a test that a lot of doctors were doing for a very long time until about 2012 or so. And then the U.S. Preventive Service Task Force, which is sort of this big kind of, think tank that makes all these preventive medicine recommendations, made a recommendation around that time that we should stop screening people for prostate cancer with a PSA blood test. And that was a pretty bold recommendation at the time, but it really changed the way a lot of doctors practice. Here we are 13 years, 14 years later, and we've kind of come back where the pendulum is now swung back, because since that recommendation was made, I think we've realized we were missing a lot of more aggressive cancers in younger people, and went back and looked at why. And so now we have, I think, very disparate recommendations for PSA screening from a lot of different organizations. But could you talk and tell us a little bit about why PSA screening was so controversial and what happened?
It was really the U.S. Preventative Task Force recommendation. So they grade all types of screening tests, A, B, C, D, and F.
Yeah.
They gave PSA testing a D rating. And the conclusion from...
Which means against it.
D means probably shouldn't do it, but
Right.
there might be some situations where it's needed, which is very poor rating. And their assumption and their main conclusion was that PSA testing was doing two things. One thing, it was leading to too many false positive tests, which according to them meant the PSA was elevated and the person didn't have cancer. They also were claiming that if you did PSAs on 100,000 people, you're only going to save 2 lives, and so that it wasn't necessarily cost effective. Now, there were a couple of problems that the oncology and urology community had with their conclusions. The number one problem was they never talked to urologists or oncologists about PSA screening. They viewed it mainly from the perspective of a primary care physician. So there were a lot of what we would refer to as landmark research articles in prostate cancer screening that they never looked at. The other thing they didn't really put a lot of weight on, which we in the oncology and urology community spend doing, is managing patients with metastatic cancer who may never die from prostate cancer, but they have very expensive treatments. They suffer a lot from the disease. And because prostate cancer is this very slow-moving cancer, they die from something else, but it doesn't mean their quality of life was made any better by having a late diagnosis of the cancer. They would have had a much better life if they would have been diagnosed early. And since the oncology and urology communities have brought many of this information back to the U.S. Preventative Task Force, they have kind of walked back their D rating. I'm not exactly sure where it lands right now, but they did remove the D rating from PSA screening.
I think right now, and whatever letter it is, it's an indeterminate recommendation. So they say it has to be like a shared conversation between the patient and the clinician, which kind of puts the onus on us as primary care doctors, to make these decisions, without clear guidance. But we'll get to that in a second.
Yeah. And I think that's a very unfair place to put the primary care doctor.
Yeah.
And, my job is easy. I only need to know this little sliver of medicine. Your job's infinitely farther because you need to know everything.
Right. A lot about a little.
Yeah.
Yeah.
And so it's a very tough place to put the primary care doctor. But hopefully with our conversation, with other conversations like this, maybe we can clear some of this up.
So is it fair to say that, and I can kind of hear this in what you're saying, like you didn't agree with that recommendation when it came down?
No, because I also always think it's interesting how they call an elevated PSA a false positive diagnosis, because PSA screening is not a diagnostic test. It's a screening test. We're just looking for who's at risk. We're not weighing everything on that blood test. And the task force kind of made it look like urologists are these knuckle-dragging Neanderthal physicians who look at one lab test and suddenly run off and start treating patients. It's a little bit more nuanced than that. We look at a lot more than just one lab test before we decide what we're going to do with the patient. And the other thing that it's missing is that it's not the diagnostic test. Now, the task force has a problem with the diagnostic test, and we'll probably get into this too, which is the prostate biopsy. Nobody likes them. They're uncomfortable. There is some risk involved. But it still remains today the only way we can diagnose prostate cancer.
And I think it's worth mentioning too, Doctor, that, when we look at that recommendation from 2012, and you can correct me if I'm wrong, it was based on really two big studies. And one of the studies we now know was actually pretty corrupted or biased, because I think that was was it the European trial? I forget the name of it, but one of the big studies conducted in Europe. And a lot of the people that were in the control group, meaning that they weren't supposed to be screened for PSA, actually got screened outside the study. We realize that now. And what that effectively did was it biased the results to look like there was no benefit, when the reality was these people had gotten screened and had gotten benefit. They had just sort of raised the floor, if you will, and kind of gave this false appearance that there was no benefit.
Yeah, that's correct. What you had was people in the study agreed not to get their PSA tested, but on their own, they kind of went home and thought about it and said, well, maybe I should get this test. Right. They got tested, they got some cases treated, and then they're still being counted in the study as having, no issues with prostate cancer.
Right. So what happened is my understanding what happened, and you can tell me if I'm wrong, is that, this recommendation was made, and then in that decade or so after that, doctors started to realize we're missing a lot of aggressive prostate cancers, especially in younger people. And I think that's what brought on this idea to take a second look and sort of change these guidelines. And the guidelines have changed quite a bit now. So there are quite a few different organizations that make guidelines for PSA screening right now. do you want to talk about what those are and how you practice in your office?
So there's probably no less than 6 or 7 different guidelines out there.
Yep.
And it seems like every medical organization that deals with men and anything with men's health has their own recommendation. So what's right and what's wrong? Well, I don't think any of them are totally right. I wouldn't say any of them are totally wrong, but I can tell you what I've kind of adopted in my practice and what I think makes a lot of sense. The first thing you want to look at are high-risk groups. So if somebody has a first-degree family member, a brother or a father, who had prostate cancer, that man should definitely be screened, and probably every year. African-American men have a high risk of prostate cancer, and for some reason we don't know, they get more aggressive prostate cancers. So African-American men definitely should be screened. And both of those groups we should start screening at age 40. The rest of the male population, you're really looking at screening starting at around age 50. And when we're talking about screening, we mean get the PSA blood test and I would say a rectal exam of your prostate. If you're okay at that point, then you could do testing every year. You could do it every 2 years. Some people even say every 5 years. I think any of those are reasonable options if your initial tests were normal. My personal thought, though, is why make a mistake? If you do it every year, you'll make sure you get it done every year. So
Right.
I still kind of fall back to the idea that if you're over 50, probably not a bad idea to get a PSA on an annual basis. That's not going to be stated in the guidelines, but I think there's a practical level to it where you just don't forget to do it. But if your PSA is really low, I do think it's probably safe that it's an every 2, 3, 4 year screening test. I think 5 is maybe just a little too cavalier.
Yeah, so I'll tell you what I do, because I do a lot of PSA testing in the men that come into my office, being a primary care office, and there are, and I just put it in the chat GPT just to be, get a little summary, and at least 5 organizations that make recommendations for PSA screening in men, and all 5 of them are different. U.S. Preventive Service Task Force, American Urologic Association, National Comprehensive Cancer Network, and the American Cancer Society, and then the European Association of Urology. Every one of them different in different ways. I feel like, as a trend, as someone that makes a lot of recommendations for screening diseases, the U.S. Preventive Service Task Force thinks too much about cost effectiveness and value and not enough about putting the patient first. And I think that's, as a PCP, where my focus is on putting the patient first. So I think they're a little too conservative on this issue for the same reasons you just illustrated. I like the American Cancer Society recommendations. That's kind of what I go with in my office, my way of navigating through all these different recommendations. I feel like if someone has a 10-year likely lifespan at 50, which most men will, they should be screened with a PSA of 50. And if they're high risk, at 45. And I do it every year because I feel like the studies were biased that said to, back from way back when. And I just think, like, I don't know. I feel like everything's changing now for the better in terms of the ability, how we figure out who gets a biopsy and who doesn't. And I just feel like it makes sense to screen now at 50.
The other thing we do as urologists is we're very focused on the trend of the PSA. To me, in my practice, that's far more meaningful than any individual number.
Right.
So the normal, quote unquote, normal range of a PSA is going to be 0 to 4.
Yep.
Now, I've had people who have PSAs under 4 that we've biopsied. I've had people with PSAs higher than 4 that we haven't biopsied. Because if I have that guy coming in and I have a PSA every year going back 7 or 8 years, I can tell what's happening with the physiology of his prostate by looking at that spectrum of results.
Right.
And if it's very flat or even going down, I'm much less worried about that gentleman than the man whose PSA is rising, because it goes to understanding what this PSA, we keep throwing this, 3-letter term around it. So it stands for prostate specific antigen. It's a protein made by the prostate, and the prostate's the only part of the body that makes this protein. And this protein's amount that you can detect in the blood will raise when there's something wrong with the prostate. Now, that something could be 100 things.
Right.
It could be an infection. It could be inflammation. It could be hypertrophic growth that's benign.
A jog or a bike ride.
A jog or a bike ride. There's studies they did about how it relates to sexual relations, and that can affect the PSA. So there's a whole varied milieu of things that can affect this number. So if you can see how it's moving over time, you're going to get a good idea, better than anything else we can measure, of what's happening in the man in front of me's prostate's physiology. And if the physiology is hyperactive, well, now I'm focusing on those things that are hyperactivity of the prostate: BPH, inflammation, and cancer. So I've already narrowed down what's going on just because I can look at multiple tests.
Right.
And the only way you get multiple tests is if they're getting their screening done regularly.
Absolutely. And just we should make the point too. What percentage of men that have an elevated PSA actually do have cancer? That's one of the real challenges of this, isn't it?
Yes. So the younger the man, the less likely they're going to have cancer. So if somebody in their 50s or 60s has an elevated PSA, it may only be 40% of those gentlemen.
Right.
Could be less. If it's somebody into their 80s or 90s, it's going to be much, much higher, maybe 60, 70%. But it's never 90%, which is where groups like the task force would like us to be. Unfortunately, that's just not how it is. That's not reality.
I mean, I've read some studies that say that PSA has like an 80% false positive rate. Like only 20% of people with an elevated PSA in some groups will actually have cancer.
Right. Again, that's where that's like the fingers on the chalkboard to me.
Right.
It's not a false positive.
Right.
False positive would mean 8 nanogram per deciliter PSA.
Yeah.
But it really was 6.3.
Right.
That's a false positive elevated PSA. That's what that means.
I see.
If it's 6.8, that does not mean to me as a urologist, you have cancer.
Right.
That says to me, you have something in your prostate that has raised this number.
Right.
I now need to do my job and figure out what that is.
Right.
Knowing that one of those things is cancer. But of all the things I can do for you to make a diagnosis, the riskiest diagnosis to make as far as patient safety is going to be the biopsy for cancer. So I'm going to work to find some other cause for that PSA to be elevated. If I can't, then we may have no choice but to look at a biopsy.
Let's talk a little about biopsy, because that's one of the things that's really changed since that 2012 recommendation too. Like back then, we didn't have the tools that we have now to really figure out who needs a biopsy and who doesn't. You have way more tools in your arsenal to look at the prostate non-invasively now and decide who does and who doesn't need a biopsy. Would you talk a little about that?
Yeah, so we have, so we'll talk about kind of 3 things. There's molecular things that we can look at, there's mechanical things that we look at, and there are imaging studies we can look at that all improve biopsies and who gets a biopsy. So on the molecular side, there's tests that supplement and support the PSA, things called ISO-PSA. We use in our practice something called the Prostate Health Index. You can use free and total PSA ratios. There's now some urine tests that they try to refer to as a liquid biopsy. And these tests can be done to supplement your PSA. Again, we're looking at some other information that we can get either from blood or urine that will tell me, is this man high or low risk for cancer? And if I can have a couple of these tests that say he's low risk, even though the PSA might be slightly elevated, then I might watch that guy a little bit longer before I do a biopsy. Now, on the imaging side of things, there's high definition ultrasound, which is available now, that can identify tumors in the prostate so you don't have to take as many samples. We, in our practice, we were the first group in Massachusetts to use MRI guidance. Right. So we'll send a lot of our patients for prostate MRIs, which is non-invasive. And if we see a lesion in the prostate, we can use that information to target the biopsy so that we're definitely getting tissue from part of the prostate where we see a problem. Prostate is, I think, I could be wrong, but I'm pretty sure the only organ in the body that we biopsy where we haven't seen anything that we're actually targeting other than the gland itself. If you have a liver biopsy, they saw a lesion in the liver. If you have a breast biopsy, they saw a lesion or felt a lesion in the breast. Prostate, we might have a completely normal looking prostate on regular ultrasound, and we biopsy it. So that's another one of the criticisms that prostate cancer diagnosis has had, is that we're doing random testing when it comes down to the diagnostic testing. And that's all valid criticism, but an MRI or a high definition ultrasound can improve on that. And then mechanically, we can lower the risk of a biopsy, where we're now seeing more and more doctors doing what's called a transperineal biopsy. Currently, most biopsies are done through the rectum, which gives a higher risk of infection. And if you get a prostate infection from a biopsy done through the rectum, these men are very sick. They're often in the intensive care unit with sepsis.
It can be life-threatening.
It can be life-threatening. So that's one reason why we don't want to biopsy too many people, but at the same time, we can't ignore that men need a biopsy. The transperineal biopsy is done through what's called the perineum, the area above the anus, below the scrotum, and that stretch of skin. They can clean that off and pass a needle into the prostate, get a sample without going through the rectum. So a little bit lower risk of infection. The flip side of it is a little more uncomfortable of a procedure. So there's give and take to everything.
Interesting. And then worst case scenario, if men do have prostate cancer, and what would you tell those men? I mean, I think that right now, prostate cancer we've never had more things we can do, right, for men with prostate cancer. I just know from my own patients, there are so many treatment modalities right now. It's a treatable kind of cancer.
Yeah, so a lot of the cancer we diagnose, 1 out of every 3 patients, we actually don't treat actively at the time of diagnosis. They go into active surveillance. And the reason for that is many of the treatments are going to have unwanted side effects, mainly to do with impaired sexual function or impaired voiding function. And nobody wants to have sexual dysfunction, but universally nobody wants incontinence. And a lot of the treatments can have the risk of incontinence with them. So if we have a cancer that can be watched for 10, 20 years, we'll watch it until that man has to be treated, because we don't want to expose him unnecessarily to side effects. Then if the patient needs treatment, if it's low-grade, small-volume disease, we now do focal therapies. We can use focused ultrasound. There's a new procedure coming out, which we're hoping to get started as one of the first areas in New England, with using steam therapy to treat focal lesions. We don't do it in our practice, but some doctors have tried even using laser phototherapy for focal treatment of prostate cancer. And we have one of our doctors in Plymouth does focal therapy using cryo treatment, where they freeze the prostate. So that, for a lot of men, really lowers the risk of side effects and can be effective therapy. Then with radical prostatectomy, which is still the most common way we treat it, the surgical treatment has improved. It's now done robotically. So the patients are sometimes home the same day. The recovery is much quicker. And then on the radiation side of things, with radiation improvements, there's now CyberKnife, where you can get all of your treatment done in 5 days, where a standard treatment of external beam radiation might take 6 or 7 weeks. Now they condense that into 5 days. And at the same time, having fewer side effects. And with radiation, the big problem we see with them is the rectum can get a radiation injury, which can be devastating for a man. So if they have a prostate that's amenable to the CyberKnife therapy, those guys symptom-wise do much better.
And for the prostatectomy, what percentage of them get erectile dysfunction afterwards?
So it depends on age. The older the gentleman, the higher the risk. So guys in their 50s, it's still pretty high. It can be a 50% risk of erectile dysfunction. Yeah. As they get into their 70s, it's getting close to 80-90% of those guys are going to have some erectile dysfunction.
That's interesting. I know that's one of the real challenges of some of these stories. All right, some of these procedures. All right, two quick things I want to ask you about, and then we're going to let you go. A couple other things you do in your office. Number one is you do scalpelless vasectomy. I'm a man with 4 children, Dr. Curran. I should have come to see you about a year ago, but I continue to play dice with my own mental health and sanity by not doing that. But I am due to come in. But for all these middle-aged guys out there like me that have decided that they are ready to hang up their cleats and stop reproducing, tell us briefly about scalpelless vasectomy and what you guys offer, because I hear it's great for my patients.
Yeah, so no-scalpel vasectomy, really what it means is we're making a very small incision. You still have to make an incision. You can't get to the tube, the vas deferens, without some type of opening through the skin. But the opening is so small, we don't need a scalpel to make it. And so we have an opening that's literally 1 or 2 millimeters, just big enough to access that tube. We can get the tube then up to the level of the skin, clip it off, remove a little piece of it, and we're done. We do the right side and the left side separately. The whole thing, you're in and out of the office 15, 20 minutes.
And without anesthesia.
Local anesthesia.
Local anesthesia only. That's convenient.
Yeah.
Yeah.
But we don't give any sedation or general anesthesia, so you can drive yourself in, drive yourself home.
Yeah, that's. I mean, I've had a few patients do it, and they say it's tremendously convenient and more or less painless and easy, and it's great. And I don't know why I haven't come in yet, but I will say that if one day you guys wake up and I'm just gone, like I'm in Mexico somewhere and you never see me again, then you know that I waited a little too long to get the vasectomy. All right, and then tell us one other thing. I know you have another expert that we're going to have in on this, but I want to just very quickly ask you about testosterone replacement therapy. I know you don't do a ton of that on your own. This is a super hot issue. We're going to do a whole episode on this coming up, but very quickly, one of the things I see in my office is a lot of men getting testosterone online. And it's dangerous. I think it's super dangerous. I can't tell you how many guys I have in my panel. I got about 2,000 patients now. I just ran the numbers today. And they're getting testosterone online from some non-reputable testosterone mill or men's health thing, maybe in person, maybe online. And I do their CBC, and they have thick blood. And there's all kinds of health risks associated with that. They're not being managed correctly. There are risks to testosterone therapy. Tell us the value of getting testosterone through a legitimate, credible place like yours.
Yeah, so testosterone replacement therapy can be very valuable to men as they age. It helps with bone health. It helps with maintaining muscle mass. It helps with physical performance, sexual performance, mental performance. So there's no doubt that there's a need for it. But like you mentioned, you can be on testosterone and develop what's called polycythemia, or thick blood. That puts you at risk for heart attacks and strokes. So a lot of the men we're treating are going into their 40s, 50s, 60s. We even see guys in their 70s and 80s. What are these guys at risk for naturally living in America? Heart attacks and strokes. Right. So in our practice, we're monitoring their CBCs every 6 months at the minimum. Right. And if they run high, we'll see them more often. Now, the treatment's actually quite easy and beneficial to society. They go to the Red Cross and donate blood.
Right.
We need more blood donors.
Wonderful.
Yeah. So, but if they're not being managed, which a lot of these online organizations aren't managing, they're just pill mills to dispense the drug, a lot of men can be in trouble.
Absolutely. And like when they come to my office and I'll do a CBC on them and I'll say, look, your blood is thick. You gotta stop. You gotta talk to, but I'm not prescribing the testosterone. So I don't really get a say. And they're under no obligation to listen to what I say. I have no ability to influence what is happening. They're getting some, remote online pharmacy that's probably not even in this country. And it's just a very dangerous situation. So everyone should be coming to your practice or a place like that and getting testosterone done under a legitimate, credible urologist.
I agree completely. The other thing they miss are what are the other things that could be causing your testosterone to be low? Could it be a pituitary tumor? Could it be a thyroid problem?
Right.
Could it be undiagnosed diabetes? There's a lot of medical conditions that lead to the low testosterone that need to be ruled out as well.
Do we put obesity on that list?
Yes, we do.
Because obesity is really because as you know, and the audience might not, adipose fat tissue is metabolically active, it's hormonally active, and it lowers testosterone levels. So that's really the problem for a lot of people, high body fat, obese, and they have low testosterone and all that comes with it.
Yes.
Awesome. All right, producer Dave, you got anything you want to ask the good doctor? You want to get into your prostate, deep dive into your prostate? We don't mean that literally.
I would like nothing more so than to do it right on this podcast, just like Katie Couric did on live TV. No, yeah, my only question was any advice for people going in for their first colonoscopy, and particularly how to interpret the results, because I know
first PSA, you mean?
Well, either, I guess. Yeah. But since we're talking about PSA, sure. First PSA. Are you looking for a clean bill of health, or are you likely to hear something more in between, like areas of concern? Does that make sense?
Yeah. So the first PSA, I think, is really the beginning of a lifelong screening process. You know, the risk of prostate cancer doesn't go away after that blood test is done. So you need to come back and you need to revisit it, like Dr. Tehan and I both recommend, on an annual basis. And what we're doing is we're beginning that pathway of following this blood test. So we're looking at the trends, and this is a starting point. So it's not a end of anything. It's the beginning.
So you're looking at it more as it's like an annual physical for your colon, for your
prostate.
Right? Prostate.
Yeah.
Sorry, prostate.
Yeah, I mean,
that's in the neighborhood.
Yeah, the women are going for their mammograms and their pap smears every year, and men need to go for their PSAs.
Awesome. All right. Well, listen, we want to thank Dr. Curran for coming in and joining us on the Modern Medicine Podcast. This was great. I hope all men watch this episode. Everyone is going to have to go and have a conversation with their doctor about their PSA screening test and whether they should do it or they're not. And I think this is super informative. There's a upside, there's a downside. Listen to this and then go talk with your doctor. Awesome. Thank you, Dr. Curran.
Thank you very much.
Awesome. All right, producer Dave, that was really good, right?
Outstanding information.
A lot of information, because this is something everyone's going to have to think about. And I'll tell you, like, even as a doctor, sometimes I have a hard time making sense of it. So I learned from Dr. Curran.
Imagine that.
Yeah.
Yeah.
Who thought? They told me it'd be a lifelong odyssey of learning when I went into medicine. And you know that it has proven true.
It is one of these things that men, and you end up talking about it like in the sauna or something.
Right.
It's like have you gotten checked out and all that, and it's no fun to talk about, but we worry about it. So
absolutely,
yeah.
and you know, Dr. Curran's still a big believer in not only the PSA blood test but also the digital rectal exam, which is something that I think a lot of primary care doctors don't do as much anymore, which he alluded to for various reasons, but certainly he feels there's still value in that. So for that good old-fashioned, is it really a physical without a good old-fashioned rectal exam, producer Dave? I mean, come on.
I just always think of the scene in Fletch where with Dr. Jellyfinger. Sorry, I know I'm not supposed to laugh, but
No, it's funny. And like, people always make fun of me, because I have massive hands. Like, look at these things. Like, the cartoonishly massive hands. So, but I can assure to the public out there thinking of coming to my medical practice, I am surprisingly gentle and with wonderful technique. So I've been told by the patients. So just please don't worry about that. But no, we joke about it. It's good. It's good to have a sense of humor about these things, but this is important. And I have had young patients in the last couple of years that I diagnosed with prostate cancer that would not have been picked up if they had gone under the previous guidelines to not do it. It would have never been diagnosed. They would have presented with metastatic cancer in 10 or 15 years, and it would have, I think, really, affected their life, their quality of life, and their quantity of life. So I have no reservations about doing PSA screening in patients at this point. I do it in pretty much everyone over 50, every man over 50. I don't do it in the women because, they don't have a prostate, so there's no point. But I do it in the men over 50, and, I believe in it. I think it's a good idea. And I think, as he alluded to, with some of these new technologies and with like all the AI stuff, they're only getting better right now. And I think the idea is about like who has cancer, who needs a biopsy. It's getting clearer and clearer, and I think that favors more towards screening.
For sure.
All right, let's talk about in the news. Are we ready? Let's change the subject.
Let's do that thing right now.
Yep.
In the news.
Yeah, let's change this up from one orifice to another. In the news, we are going to start with, we were just talking about the prostate. We're going to start with the health effects of competitive eating. July 4th was last week. I found this great article in the Sporting News. Here's what happens inside the body after Nathan's hot dog contest. This is a great article. It's got a picture of that clown, Joey Chestnut, like wolfing a hot dog, by the way, on the front
goat.
page. Oh my God. But what this article talks about the competitive health risks of competitive eating. Let me just read a little bit. A study from the American Journal of Roto-Angiology, Radiology, found that competitive eaters are at risk of morbid obesity, shocker, profound gastroparesis, that's basically like when your stomach stops like contracting and food gets stuck in there, and intractable nausea and vomiting, and even the need for gastrectomy, meaning they have to rip out a part of your stomach. So not, I think, I mean, come on, this is just common sense.
Well, right, that's what I was thinking.
Right.
Like, newsflash, you eat, 30 hot dogs in one sitting, there might be adverse health effects to that. When you watch, if you ever see the Nathan's hot dog eating contest and Joey Chestnut doing his thing and everything, what's surprising is some of the people look like they're in relatively good shape.
Yeah.
And Joey Chestnut's not fat.
No, he's
just
lean.
a guy.
He's lean.
So, I mean, I tend to think of him as he's just a freak of nature. I mean, but yeah, for those thinking that they might like to get into this hobby, I don't know what would possess you unless you think you've got that absurd, strange talent.
I think there are few things that we as a nation do that are more disgusting than competitive eating. I really believe it is vile and repulsive to me in every way. I have no interest. I can't watch it. I think it's disgusting. I think one hot dog is kind of disgusting. 76 hot dogs in a 10-minute span is just self-abuse. It's gluttony, and I have no patience. I don't even want to see it.
Yeah. I saw a documentary on people who eat hot peppers competitively.
Oh, yeah.
Which is its own thing.
People have died from that.
Yeah, I'm not surprised. There's a woman who's, I think she's Guatemalan or something, sort of an exotic looking woman you wouldn't think would be a competitive eater. I mean, now they're not eating huge quantities of these things, but no one person like you and I could not eat one of these things. These are brutally hot, spicy, whatever you call it. And they showed her, and she's really good at it, and she sometimes wins. But then for like 3 or 4 days, her body shuts down.
Right.
She's like in bed. She can't do a thing. It's not normal.
No, it's not normal. And people have legit died from eating these like super hot peppers. That's another one that just like completely escapes me. Like, why I can barely handle like old El Paso taco seasoning. What are these people doing? Eating these like Carolina Reaper peppers. Like, good God.
Yeah.
Are you that bored? You need to do that to yourself?
Sometimes I eat the pepper that they throw into like General Gal's chicken by mistake, and I'm like, I got to lie down for the rest of the night.
Totally. What about, you ever get sushi? You mess with the wasabi? Because that's a hit.
I like wasabi.
I can do a
sure.
dash.
Sure.
A dash. That's about my upper limit.
Yeah.
Because here's the thing. Like, I'm Arab, half Arab, and I grew up on Arabic food. Arabic food is flavorful. It's not necessarily like spicy, right? Like Mexican food is like harsh spice to me.
Sure.
It's very different.
Yep.
All right. Next story. Let's talk about this. Scientists say creatine may help fight depression. Creatine could have untapped, this is from Science Daily, could have untapped potential as a depression treatment, but the evidence is promising, not yet persuasive. Creatine is best known as a muscle-building supplement. Scientists are now investigating whether it could also help depression by boosting brain's energy supply. A review study published last month examined 5 randomized clinical trials involving 238 participants and found mixed results. 2 studies found that there were benefits to major depressive disorder from taking creatine supplementation.
So I've taken creatine before
Yeah.
during my days when I try to get really ripped,
Yeah.
And I found it worked, but in a limited fashion. But it's definitely a stimulant, right? I mean, it's like it kind of makes you feel like your pupils are doing that Incredible Hulk thing. It's like, zzz, and it gives you a little pump. But I didn't find it did too much else. So this is surprising to me. But what the hell? I mean, if it helps.
Yeah, I mean, a couple things. Like, so first of all, they looked at 5 trials. They were randomized controlled trials, which is great because that limits the possibility, or eliminates minimizes the possibility of bias, right? Because randomized controlled trials are the best gold standard, but only 2 of them were positive. So it's like you flip a coin 5 times, you get 2 heads and 3 tails, right? So I don't know. I'm not convinced that there's anything real here yet
Mm.
I read this article based on what I see, but this is definitely one of those like things where we have to fall back to the old boring adage: more studies are needed.
Yeah. Well, on the other hand, if it works, great, because it's a lot of science's great discoveries have been made by accident, right? So creatine was created to give everybody a pump before their workout, and who knew it might be able to do this? Do you remember when creatine first sort of made the news for what reason? Do you remember in the late 80s, I want to say. Brady Anderson, who was a ball player for the Orioles, he came out. He came to spring training one year totally jacked. Hit maybe 18 home runs the previous year, and all of a sudden hit 50.
I remember that.
And he quote unquote admitted to taking creatine, which we now know creatine was the least of what he was taking.
Well, that's just it. I don't think what he did fell into the category of creatine and peanut butter sandwiches. Like, I think he was
that's just what he would cop to, right? Yeah.
But yeah, I mean, like, I've flirted with I don't take creatine. I feel like as I get older. And sometimes recovery has become more of an issue for me for my workouts because I work out every day. That I've flirted with the idea of maybe trying it again for that. But it's interesting to see the possibility it may have benefits. And one interesting thing about these studies was there is actually a biological basis to why creatine might help, because they think it does elevate levels of serotonin and other neurotransmitters. So that's always a good starting point, and we'll see what the future studies show. It doesn't mean you should go start ripping creatine because you feel down,
right.
But it's just something there'll be more studies on this. We're so desperate for treatments for mental health. I mean, we're basically like leeches. I mean, really, they used to throw leeches on people because they didn't know what the hell else to do. Right? And think of the things we're trying to treat mental health. We don't have great treatments for mental health problems still to this day. And this is why people try anything, whether it's ketamine or LSD or medications or anything. People will try because it's such a vexing clinical problem.
Yeah, but I mean, time marches on, and things that we think are second nature now were not back in the day. When you said leeches, it always reminds me of the really old Saturday Night Live sketch with Steve Martin as Theodoric of York, the medieval doctor, and the people would come in and say, I've got incredible stomach pains, and he says, well, a good bleeding will take care of that. Let's get her over to the bloodletting station. And it's like, but yeah, that's but I'm glad we don't do the leeches anymore.
I will tell you this: there are things that we do today that a couple hundred years from now, people will look at like we look at leeches.
Exactly. That's what's interesting.
No doubt about it in my mind. As someone that's practiced medicine for 12 years. Okay, next story. This is from CNN Health. We talk a lot about AI on this podcast, and for good reason. It is a super hot topic, and it is coming. The robots will be taking over at some point. Is AI ready to take over your prescriptions? Doctors are wary of Utah's automated prescription refill program. This is a prescription refill program that quietly launched in Utah earlier this year has kicked off a big medical debate. Is AI ready to take over tasks that until now could only be performed by doctors? The program allows Utah residents to skip the doctor's office and get their prescriptions refilled online by an AI chatbot called Doctortronic. It is seemingly simple step towards making healthcare more convenient for patients and prescribers. It's a precedent-shattering milestone that has set off alarm bells for doctors. Producer Dave, your thoughts on AI chatbot serving the role as prescriber?
Well, prescriber sounds pretty serious, but I'd say like a lot of things in AI, like it's maybe we should proceed carefully, but we should never say absolutely no to anything. I might have mentioned this on the podcast before, but I do use ChatGPT a lot, and I asked ChatGPT something about my allergies or something, and the chatbot says, Dave, a few months ago, you mentioned you had like a little bit of a rash, like that might be related to this.
Right.
And I had forgotten I had even told the ChatGPT that. So I was like, oh, that's cool. You remembered that. Thank you. So that just leads me to believe that imagine if there are things that we might say to ChatGPT that we would never mention to our doctors that we think maybe are too minor. And a good chatbot might be able to, prescribe, I don't know, but to be able to flag something and say, hey, you mentioned this last year around this time. You might want to look into this.
Yeah, so. That's one of the strengths of the whole thing. I use ChatGPT all the time, both personally and professionally. In fact, funnily enough, for the preparation for this podcast, I had asked some stuff about ChatGPT. And Chat, as I call him, we're on a first name basis. He knows that I'm a physician. But what was really crazy is ChatGPT literally said, as a fellow physician, I'm sure you can appreciate. He identified himself as a physician. And I screenshotted it because I thought it was wild.
Yeah.
But, the AI is coming. I like AI. As a doctor, I like AI. I find the information I get on there useful. I mean, this is coming. Are we ready for it yet? I don't know. I have concerns about this because part of what I do in my job is monitor people on these medications. Why? Because sometimes unexpected things happen, right? So when you're on blood pressure meds, you should come in twice a year, right? When you're on diabetes meds, you come in every 3 months. Why? Because we might pick up something on your blood work. You might have a side effect. There might be a problem. Is this AI ready at this point to make those kind of calls? And if it is, what does it do with them? You know what I mean? Does it get people, does it check blood? Does it make orders? Does it, if someone needs a test and, if someone's on a blood pressure med and they're having a side effect, does ChatGPT know how to, or the AI need to know how to follow up and refer someone for a test or a visit like I do? That's my biggest concern.
And is there any possibility of, nefarious people hacking this for their own purposes? I don't know.
Yeah.
Because you could impersonate someone online a lot easier than you can going into your doctor and asking for a script.
Great thought, with controlled substances and stuff like that. Who's monitoring that stuff? We've come so far in how we are able to, control people that are using dangerous medicines, will this be able to do it? But I do think this is interesting because this is a step. This is a step of what's coming. And here's the reality. We have a huge doctor shortage in America, Producer Dave. We don't have enough providers. We're training all these NPs and PAs to fill the void. Even still, we're going to not have enough providers. So something is going to have to fill the void. And I really think that something is going to be AI at some point.
I agree. I welcome our robot overlords.
100%. Great line from The Simpsons, by the way.
Right.
Great line from
Glad you picked
Kent Brockman.
Kent Brockman.
Absolutely. Okay, next topic. This is an interesting one. This is the strongest predictor of colorectal cancer. Under 50 increases your odds by 850%. This is from the extremely credible medical journal known as the New York Post, Producer Dave. Ignore this red flag. Do you follow their Facebook page?
At least it wasn't on page 6. I do end up, I don't know if I follow it per se. I end up reading a lot of things from the Post, yeah.
Absolute trash ass collection of clickbait, right?
Yeah.
The stuff they post, like alien invasions and crazy medical shit. Oh, pardon my French.
Yeah.
And it's wild. Blurt that out. I don't like to swear.
Okay.
Okay. This is the strongest predictor of colorectal cancer. Ignore this red flag, literally, and it could come back to bite you in the rear. A new study has identified the strongest predictor of colorectal cancer in adults under 50, increasing the odds by a staggering 850%. And that is, of course, the New York Post will make you click on this like 6 times before it tells you what it is. So I'm just going to spoil it. It is rectal bleeding. It is rectal bleeding. If you're a young person and you have rectal bleeding, you have a much higher risk of having colorectal cancer. We are seeing, Producer Dave, way more young people, and I mean people under 40, let alone under 50, with colorectal cancer. So rectal bleeding is a big red flag for colorectal cancer.
It should be pretty obvious, right? I mean, that's. I mean, the human body is a marvel, of course, and I don't know if it's bred into us. I think it is to some degree that blood equals danger.
Right.
It's like
Fair.
you're playing basketball and someone's like, hey, you're bleeding. That you stop and you take a look. If you see blood in the toilet, that should provoke you to ask some questions.
Right, and it absolutely always talk to your doctor if you see that. I will say that, do you know who bleeds rectally at some point in their life? Everyone.
That's true.
So that's the danger. So most people that bleed rectally don't have colon cancer. Everyone bleeds rectally at some point. And, you look for those red flags. Rectal bleeding that doesn't go away, right? Like if you have bleeding a couple times a year for a couple days at a time, talk to your doctor about it, but probably not need to push the alarm button. Now, if you're bleeding consistently for 3 months, 6 months, and it doesn't stop and it's getting worse, and then you're losing weight and having pain and your appetite's poor, I mean, that's the stuff you really got to watch out for. But the challenge of this is that, everybody bleeds rectally at some point, so it becomes hard to know who's who,
It's just like the third or fourth time in this episode of the podcast that the show has come to an end. And it's not over yet. It's just come to an end. Sorry, I was going for a play on words.
There you go.
I'll see myself out.
Well, we're gonna call this the Orifice episode of the Modern Medicine podcast.
Right.
That's this episode. Okay, and then I think I only got one left here, and then we're gonna get to some of the fun stuff. It's summertime in New England. We have to talk about tick-borne illness. This is another hot topic, tick-borne illness, alpha-gal syndrome, now considered public health threat in Massachusetts. I think we might have talked about this last summer, but alpha-gal syndrome, a tick-borne condition that can lead to potentially serious symptom of meat allergy, and this can be very, very serious, make people very sick, is now rising. This is from a tick that was previously not in this part of the country, called the Lone Star tick. And over the last 2 or 3 summers, the Lone Star tick has found its way up north. And now, especially on places like Martha's Vineyard, Nantucket, and now even Cape Cod, a huge problem with meat allergies. People oftentimes don't even realize they've gotten bit by this thing until they have like a cheeseburger and they get a serious allergic reaction.
Well, that's really odd. And it's one of the most frustrating things about nature, that something that small can bite you. You don't even know about it, and it can affect you for the rest of your life. I had a friend that had Lyme disease from just a tick biting him one summer up, he's up in the woods somewhere. And he's dealt with that his whole life. It's awful.
Yeah, I mean, ticks are really scary. I think ticks are scary because well, first of all, this Lone Star tick is actually bigger. So
at least you can see it coming.
If you check, you shouldn't miss it. The tick that spreads Lyme, it can be the size of a poppy seed. And it can spread Lyme. So you got to really check carefully. So always check, the places you don't want to check. For example, the perineum, right, which is like Dr. Curran said, that area colloquially referred to as the gooch or the taint.
Yeah.
But like that place, the back of your hairlines, behind your ears, your gluteal cleft, again, your butt crack, right? This is where people get ticks legitimately.
Yeah.
And it's a little bit of a selection bias because those are the places we don't look. So, if a tick is crawling on your arm, you usually see it and flick it away and it's not a problem. But when it gets into one of those places, people don't see it. So you really have to specifically check, especially if you're outdoorsy. And, as scary as this alpha-gal tick is, Producer Dave, I'll tell you, the Powassan virus, that's another tick-borne one that's increasing. That's even way more frightening. Have you heard about the Powassan virus?
No.
So this is a virus that the tick, Lyme disease, Ixodes tick transmits. And what's scary about this is it can transmit in like 10 minutes, whereas a Lyme disease takes 24 to 48 hours. So crazy.
Just crazy.
And it's way more deadly, too. So scary stuff.
So there's not much we can do about this, unfortunately, except watch for symptoms, right?
Well, no, that's not true. I mean, we can check ourselves for ticks. We can wear insect repellents. We can practice caution, preventive medicine. And, Lyme disease is very treatable. In fact, all the tick-borne illnesses we have, except for Powassan virus, are generally treatable. So, if you're concerned, you can talk to your doctor. They can do a simple blood test and see what you have. Most people that get Lyme never even know they have it. They think they got a cold or a virus. They clear it. Their immune system fights it off, and they're fine. That's the truth.
Oh, okay.
All right. You ready to talk about the non-medicine topic of the week? We're going to wrap up this medicine nonsense and have some fun.
The doc is off the clock, so it's time for the non-medical topic of the week.
All right. I just threw the pager in the garbage, and I'm sleeping in the closet. It is the non-medicine topic of the week.
Do you still have a pager?
No.
Oh, okay.
No. Cell phones.
Yeah,
the way to go now. Cell phone. I do have a cell phone, a work cell phone, but not a pager.
Sure.
All right. So we're going to talk about a couple things today. You're a Disney guy. Do I remember that correctly?
Absolutely right. Yeah.
Yes, you have it.
Yep.
Yes. I want to talk about this kid that fell down the drop on Tiana's Bayou Adventure at Disneyland, formerly Splash Mountain. 54 feet, I believe that is. I think if you've ever been on this ride, it's a terrific ride.
Yeah. Have you been on the new one, though, the Tiana?
I have. I went this year, yeah.
All right, so we're looking at it now.
Oh,
there's no sound to this, so we're just, if you're watching the video version of the pod, you'll see it. Otherwise, he'll provide a link. But let's just say you clearly see the kid just kind of casually get out of the log flume at the very top of the slide, and it says he fell 50 feet. It didn't look like that. It looked like he certainly could have gotten messed up, but I would have been more concerned about him hitting like some metal beams or something on the way down, like hit some piece of machinery on the way down. I mean, he's falling, but it almost looked like he was going down a rough water slide. I'm glad he's not hurt, but what's your reaction to this thing?
Well, I think it's terrifying. First of all, the kid must have just completely freaked out. Because when you're on the ride, it is a little scary when you get to that moment at the top.
Yeah.
And, you're like, oh, here we go.
Yep. So yeah, the question is why he did it, and I guess that might have been it. He just might have been like, "Screw it, I'm out."
I'm out.
It's amazing it hasn't happened more often. I guess you know.
Yeah.
So yeah, there were no seatbelts on that thing, but
They put that that harness thing, metal. It's pretty hard. I don't think I could get out of it.
Is there a bar? Yeah, you're right. There is a bar.
Yeah.
There is a bar that comes down on your lap.
It's a bar with like a thing over it.
But I guess if you're a wiry 13-year-old kid, maybe you can wriggle out of that.
That thing.
No, I don't think they do the thing on top of your shoulders on that. No,
they do the bar from the bottom.
Yeah,
it's from the bottom.
your waistline.
Right.
Yeah.
But that thing when you drop down, I think you hit speeds up to 45 miles an hour for a second.
Yeah.
So he's lucky he didn't get hit by the next one. That'd be like getting hit by a car.
Yeah. It happens. If you want to go down sort of a dark rabbit hole, look at the Wikipedia page for theme park fatalities.
Oh yeah,
there have been plenty. Not too many at Disney.
Right.
It's usually like somebody had a heart attack on Space Mountain. Well,
right.
That's not too much Disney's going to be able to. This thing, it's kind of a shame because I wonder if it might. There was actually a report like a month later that the same thing happened. Kid got out of the thing on the former Splash Mountain ride, but a worker noticed it immediately and just stopped the ride.
Shut the ride off,
yeah, exactly. So no scary fall there, but.
Dude, it's scary, but just ride it out. It's over in 2 seconds, and then you're fine. You'll be laughing. It's a lot of fun. Everyone loves it.
Yeah, I know. I hope. I hate to be like a Disney yes man, but I hope Disney doesn't face too many repercussions from this, because no matter how many safety precautions you take, there'll be someone who freaks out or some jerk who, I'm sure people have gotten off on it's a small world, right? Somebody's drunk and gets out and decides they're going to dance with the little Eskimo or something,
Right. What about the guy that, speaking of competitive eating, what about the guy that tried to eat like a Wendy's meal on the roller coaster at Six Flags? Did you see that?
No.
He got banned, a lifetime ban from Six Flags. He tried to eat like a burger and fries on one of their like super intense, a ride that would put that ride, Splash Mountain, to shame. Like one of those crazy, coasters. And he tried to eat a whole meal, and they saw him. He was going to go viral with it. He's lucky he didn't choke to death, because you're facing like how many G's of force when you're in some of those rides. So they saw him. They immediately confiscated or like whatever.
Banned him from the park
for life. And now he's banned from Six Flags for life.
Well, you get what you deserve.
110%.
Yeah.
Crazy story, though.
Sure.
All right, let's talk. It's summertime, so I thought we could do something a little fun this week. Let's talk about Would You Rather Summer Edition, okay? We've never done this before, okay?
Yep.
So I've thought of some summer things that, what would you rather do? These are summer kind of theme things, two things that could happen. So I'm going to start. July 4th last week, would you rather a drone show, Producer Dave, or fireworks?
I guess I'm traditionalist, although ask me in a few years after I've seen a few more drone shows, because I think they keep getting better. But I'll still go fireworks, despite the fact that it's just sort of interesting that fireworks haven't really progressed since we were kids. They're still it's still kind of the same show,
totally,
but it's still fun. It's tradition. So how about you?
100% drone show.
Really?
Couldn't care less if I ever see another firework.
Really?
Except one exception. If I go to like Disney and they're like the real deal fireworks, that's different. That's pretty cool. But like the local stuff, I'm all set. Couldn't care less. The drone show, did you see the video of the one they did in Boston?
No.
Oh my God. Check it out.
Really
it's
good.
Great. They got like drones, like they got guys throwing teas off the Tea Party ship, and they got Patriots with muskets, and they got Paul Revere and the Old North. It was awesome.
It would seem to be the future, because I don't know if this is a thing, but I think safety-wise, it's probably a lot safer to do a drone show than a firework. I mean, granted, when every Tom, Dick, or Harry gets their hand and tries to do their own drone show, they'll probably mess it up somehow.
Yeah.
So I'll check out some drone shows.
I went down to Green Harbor Beach for the 3rd of July a few years ago. I go every year, and some guy had a huge thing of fireworks, Producer Dave, and he accidentally fired a bottle rocket errantly, and it landed like 50 feet away into this pile, and he lit his own pile of fireworks, and it took like 2 or 3 minutes to happen.
Yep.
But it was terrifying.
Yeah.
And there's a viral video of it, by the way. You can find that on YouTube.
Oh, it's a bunch of people sitting on the front yard, and is that the video you're talking about?
It's on the beach. It's on the beach in Green Harbor.
Different one.
And people were like running for their life. Me and my kids were like 75 yards away from this, and we booked it.
Yeah.
But there were people that were closer. It was like literally hundreds of people running, bombs bursting in the air. Like it was insane thing, but like it was just like a 1 in 1,000 shot where this idiot he misaimed the bottle rocket, and instead of going up, it went like this and landed right in the absolute wrong spot. And very lucky someone didn't get hurt.
Well, yeah, there are injuries every year, and it's human error because some people can be idiots and they don't follow the instructions.
Are we calling those people human though? Just when we subhuman error.
But
maybe?
it's also they're buying like a big box of explosives they bought on the side of the highway in someplace in New Hampshire. You know,
Right.
it's not. I mean, I don't feel completely safe with these things. You know,
100%. Like those Roman candles,
Yeah.
these like the size of a baseball bat. And it's wild. It's out of control. All right, next one. Would you rather get bit by a dog or bit by a human?
I thought about this. I think I gotta go human because I think the human has feelings and emotions, so there's a better chance it's not going to be as vicious. And dogs' teeth are, I think, a lot sharper than ours, aren't they? How about you?
Dog. 100%.
Really? You
dog.
take the dog?
Oh, I take the dog.
Why?
Humans are dirty. We're dirty creatures. We got crazy diseases you don't have to worry about. I'll take my chances with a dog. I think their mouths are cleaner.
Wow. Okay.
Less likely to have hepatitis or HIV, right?
Yep.
I'll take my chances with the dog.
All right.
All right. Central AC or pool?
Thought about this too. Pretty easy. Central AC. And not because I don't love a pool in the summer. I certainly do. Used to have one. Enjoyed it. But AC is 24/7.
Yeah.
You know. How about
Yeah.
you?
Well, if it's just your standard 80-something degree day summer, I'll take the pool. But when we
Okay.
get days like these super hot heat wave days, then that's where you really would want the central AC. So I guess with the advent of global warming, I think you kind of reluctantly, I would have to probably go central AC. But I love a pool. I love swimming pool.
I love a pool too. You have a pool in your home, right?
I
Yeah.
do not. In
Oh, you
Dedham.
don't?
I have my parents' house has a pool, so we're there all the time. And then I have a house in the Cape with a pool.
I follow Dr. Tien on Facebook, so I see him all the fun stuff he does with the kids.
Lots of swimming.
Yeah.
Absolutely.
Sure.
Lots of swimming. Keep them busy. Okay, this one's kind of step. Step in dog poo or step in gum? What's the worst for the summer?
The worst has got to be poo. I mean, yeah, I mean, the only argument you could make for stepping in gum, I guess, is it could ruin a certain kind of shoe, I guess. But dog poo is evil.
It's tough.
You?
Well, I would say dog poo is worse, but I think it's closer than people think. Have you ever stepped in gum?
Yeah, I have,
It's a
I guess.
terrible experience.
It is, and it takes a while to clean off. Whereas the poo, it probably is a quicker cleanup with
Quicker
the poo.
cleanup.
But the smell, man.
But you can't get that gum off your shoe. Like once you step in
Yeah.
shoe with a gum, it's gum with a shoe. It is never the same shoe. There's always a little bit of gum in those little grates in there. And stuff.
Bringing it around, guess what they don't sell at Walt Disney World?
Gum?
Gum.
I believe that.
Yeah,
100%.
I think it was Walt Disney's idea because you walk in any gum is a
Terrible thing.
it's a plague on our
Terrible
society.
thing.
Yeah,
Cancer on our civilization.
yeah. You walk to any like sports arena, any like public place. Just take a look down. I mean, that's why the janitors carried the those scrapey things. But jeez,
I'm
gum's
actually
everywhere.
getting my car detailed tomorrow. My cousin does this Boston's Best auto detailing, comes to my office, comes to wherever you are, home office, and does it, right? And the reason why is because I've been buying my kids gum. And I went to go clean my car the other day, and there's like huge clumps of gum in the back seat of my car. I'm like, what are you savages doing to my Volvo that I just leased last year? So I had to get it professionally cleaned. But you're right, gum is just an absolute scourge.
It is.
It's a terrible thing. Okay, last one: poison ivy or sunburn?
I've actually never had poison ivy, knock on wood. So I think and I know it's bad, and I hate having rashes. I do get rashes occasionally for various things. But I guess I'll go sunburn because I feel like I've been through the ringer with sunburns. I'm like battle tested. So as long as it's not a severe one, now I'm moving the goalposts.
Some sunburns can be nasty.
Yeah.
Some sunburns can be sunburn 100%.
Yeah.
I had poison ivy once in my life. Bought my townhouse, first townhouse. There was brush out in the back.
Oh.
I said, I'm going to take care of this. I don't need a landscaper, Dave. I'm going to take care of this myself. Got out there with like the shovel and the clippers and the bags. I was covered head to toe 2 days later in poison ivy. It was painful, itchy. I mean, like I was probably 40 or 50% covered in poison ivy. It was awful. And I felt like shit, tired, because I was just exhausted, right? Probably because my body was like fighting off and like making this inflammatory response.
Yeah.
Dude, it was no joke. So
all right.
I will deal with the 1 to 2 days of the sunburn any day.
Yeah.
All right, and then let's go. I think that's all we're going to take. That was all we had. That's all I had.
Excellent segment. Let's do that again.
I think we should, absolutely. And then let's go to the Boston Sports Minute. Now we got a lot to talk about, dude. Oh man,
it's the Garden. It's Teddy Ballgame, Yaz and Poppy and Noma. It's Brady and Larry and number 4 Bobby Orr. It's Fenway Park. It's the Boston Sports Minute. Let's go.
Let's go. All right. There's a lot that happened in Boston sports in the last few weeks. I mean, the elephant in the room, Producer Dave. I want to hear your thoughts on Jaylen Brown getting traded for next to nothing. My jaw dropped.
My reaction was probably what everyone else's was. One, what the hell? And two, why didn't we get more for him? And I thought, when I first read it, I thought it was a hoax. Well, this can't be right. Paul George is this aging veteran who got this bloated contract and become sort of one of the forgotten stars of the NBA, not a current star of the NBA. But I do like a good counterintuitive argument, and I do like a good counterintuitive move. And there are reasons why this trade makes sense. And now under the new NBA cap rules, it's become almost prohibitive to have 2 superstars on the max contract. You just can't. You just can't do it. Well, that's what I'm told. I'm not a capologist or anything. So I think this might end up being, dare I say, a good move, or at least it doesn't feel like a good trade. Like we don't get excited to get Paul George will do a couple things, but in terms of the future of the team, I think it was probably the right thing to do, and that's why you need a GM to make those tough calls. Theo Epstein traded Nomar Garciaparra, the face of the franchise.
Hated that trade when it happened, by the way. We all did, right?
We all did. He was
won
the
a World Series.
Right. Yeah. And we won a World Series. So what do you think?
I mean, do you think that this trade was made because they legitimately believe that this will help them win a championship, or do you think there's some ulterior thing, like they're just trying to cut costs?
A and not B.
Okay.
I think, interesting. Right where you're sitting, we recorded a podcast the day before the Jaylen Brown trade with the president of the Celtics. This wasn't my podcast. It was a podcast called the Brilliant People Podcast. And the guest was the Celtics president, whose name I always forget. Not Brad Stevens, but more of the business guy. Anyway, the point of it is he was talking about the business of the sport, and there was nothing that, I mean, now, mind you, he might have been given the company line, but there was nothing that would suggest that they would make a move like this. So I don't think it came from above. Yeah. I mean, they replaced the big bloated contract with another big bloated contract, but they get out from it. So I believe them when they say it's flexibility. I mean, I actually think, we always try to read between the lines, but I think what Brad Stevens said was true. He said if the rules were different, we wouldn't be having this conversation. And I do think maybe they do look at analytics. I think that's true. And I think they think he's a very good player, but maybe an overrated player.
Well, there was a great article in the Globe 6 days ago by a guy named Jeremiah Engelman, who is a former analyst that worked for the Dallas Mavericks and the Phoenix Suns. And I recommend everybody read this article because the headline of the article is why the Celtics actually won the Jaylen Brown trade. And he gets into some of the analytics and how an NBA executive might look at Jaylen Brown as a player and some of the sort of next level statistics that kind of support that maybe Brown wasn't quite as good as we all thought he was. Now, I want to be clear. I hated this trade, and I still hate this trade. I wanted them to run it back with Tatum and Brown and take their chances. I think they would have had as good a chance as anyone in the East. But I think as time has passed over the last week, I agree with you. I don't think there was ulterior motives here. I think you have to take Bill Chisholm at his word. Give him 5 years. I know nobody wants to do that. We're the torch and pitchfork society now. We want to hang people at the stake when they do something that we don't like.
Right.
This might set them back this year. Let's see what happens over the next 3 years. I think there is an argument to be made, not saying I agree with it, that this was the right thing to do for this team winning a championship. And they lost in the playoffs terrible 2 years in a row. So let's face that. That's the reality.
Yeah. And so just running it back, might have given us the best chance to win next year, but maybe not. How many times have we thought this team is going to have a down year now, and no, so-and-so's hurt or whatever, or we gave away Holiday and Porzingis and Big Al Horford. Brad Stevens has been a master at replacing those parts with people that have become stars. So I say we give him a chance. But Rich Gotham is the guy who was interviewed the Celtics.
And unless we all forget, producer Dave, let's just remember how bad this team's playoff exit was. Losing to that 76ers team, who then got crushed, embarrassed, and pummeled by the New York Knicks. I believe they got swept, or if it wasn't a sweep, it was a gentleman's sweep. So the Celtics are further away probably from a championship than it felt like.
We didn't have an answer for Paul George, ironically.
No, that's so ironic, 100%. Yeah. Okay, let's shift gears and let's talk about the other big story in town. I'm going to eat some crap on this one. Yeah, big time. The Red Sox have gotten absolutely torrid hot.
Hottest team in baseball.
Hottest team in baseball. They've won 9 in a row on the road, swept three series on the road, first time since 1977. That has happened. They have won something like 15 of 17 games going into the All-Star break. They're half game out of a wild card right now. Producer Dave, what does the second half hold for this Red Sox team? And are we going to have a baseball season this year, a real baseball season?
I think we will. I think unfortunately, I don't think the ceiling is very high unless we make a move for at least one bat. They still can't really hit that much. They hit enough, but I did say I don't have to go back and see how fervently I said it, but because last time we did the show, we were predicting their immediate demise, which was obvious. They just couldn't get out of their own way. But I did say the pitching. I think you probably did too. The pitching,
we both did.
Just deep. Great starting rotation and deep. I maybe use another arm in the bullpen, but I feel like every time they're throwing out there a young guy who can go as many as 6 or 7 innings and only give up 1 run, and they just keep doing it. So and there's depth there, and we've got our 2 best pitchers are injured, right? Suarez and Crochet. Yeah,
right. It's been amazing. No team with starting pitching this good should have ever been that bad.
True.
And I stuck with them. You remember the first 2 episodes in April and May, I was on board. I think like many Red Sox fans, I got to the point where like I just threw my hands up because they were so frustrating and bad for so long. But you know what? All I can say, Producer Dave, is there room for these size 4 teams back on that bandwagon and a man because I'm right back on and I think 100% we're going to have a real baseball season. They're going to get Garrett Crochet back. That's going to really help them. They're going to have the best starting pitching in Major League Baseball when Garrett Crochet comes back. And I think the real question on this team and what we should be talking about is what are they going to do when Roman Anthony's healthy enough to play? Because you can't help but wonder, Mayer gone, Anthony gone, they finally start winning games. Is there a toxicity there? Is there a bad attitude?
Oh, no.
You know what I mean? So do you bring Roman Anthony back to this thing? And does that upset the chemistry?
Trade him for Paul George.
Oh, my God.
I don't know. Roman Anthony is still kind of a ghost, right? I mean, we still haven't really seen what he can do. Yeah. He did, at some point, I think, become a little overrated. But you are welcome back on the bandwagon. I know this because the Dropkick Murphys taught us, don't blame us if we ever doubt you. You know we could never live without you. That's right.
That's a great line.
So
Inappropriate.
There you go. Yes.
No, I mean part of being a fan is being frustrated, and what wasn't frustrating about this team. And I'm far from the only one that jumped off the bandwagon. In fact, I think I stayed on way longer than most people.
Sure.
But look, it never should have been as bad as it was. Shame on them for starting off like that, but as far as I'm concerned, they're a game below 500 or 2 games below 500, half game out of the playoffs. Baseball season doesn't start until the All-Star break. I don't care how they got here. I don't care what happened. They started terrible and then were great. The bottom line is if you're half game out of a playoff spot at the All-Star break, you're in it. So,
and Craig Breslow might not be so bad after all.
He might not be.
He's made some good moves.
Yeah, Contreras, I mean, great move. And I mean, just getting rid
How
of
about Sonny Gray?
Sonny Gray, great move. Getting rid of Story, Anthony, and Mayer. I mean, I don't know, just things that make you go, Right. All right. Very last thing. Let's talk briefly about our Patriots before I let everyone go. You go. What do you think, producer Dave? Jeremy Fowler came up with his quarterback rankings on ESPN.com, brilliantly timed to the Major League Baseball All-Star break. What do you think Drake May ranked in his ESPN quarterback ratings?
Unfortunately, I think I saw this. I think he was 8th.
Yes.
Is that right?
8th,
Yeah. And you know what? My reaction was, as soon as I saw the headline, I thought maybe it's the old-fashioned Boston, put down sports fan. I thought, I bet he's not even going to be on here. And when I saw him 8th, I'm like, that sounds about right.
Yeah.
I think it sounds about right. You can't put him in the same category as Josh Allen or Mahomes or even like a Burrow. But part of the write-up was I just got to, or some insider said, I just got to see more of him. And that's
I
true.
would take Drake May over Joe Burrow.
Would you?
Now, 100%. And I think one of the stories of this NFL season is you are going to see the narrative flip on Joe Burrow when the Bengals have another disappointing year. Wait and see. Remember I said that?
Yeah.
Because he has made the playoffs 2 of the last 6 seasons and not in 4 years. So just saying, the narrative's starting to flip.
But
on
he
Joe
at
Burrow
least went to a Super Bowl,
in his
right?
second year.
Yeah.
Yeah. But that said, like, I would take May over him. I can't blame them for putting Burrow ahead of them. Fine, you could argue it. The guy that really burned my backside that was ahead of Drake May was Justin Herbert. He has no business being in the top 10. Like, come on.
Has he even won a playoff game?
He's been horrible.
I'm not sure he's won a playoff game. Drake May at least went to a Super Bowl. He's been to a Super Bowl, so
exactly.
It's something to be said for that.
I thought it was ridiculous that May was ahead of that.
Was Darnold on the list?
Darnold was like 12 or 14. He's honorable mention, so he didn't even make the top 10.
Well, which is interesting because he went to Disney World. He's the Super Bowl MVP, right? Oh, was he the MVP?
Right.
Maybe he wasn't. Whatever. But he obviously won a ring. And in the NFL, you need both. You need a great QB, but you can see a lot of those QBs on the list haven't won a ring.
That's right.
Josh, in fact, most of them haven't. Josh Allen, Lamar Jackson, Herbert.
None of them have, except for Mahomes.
Mahomes is like the only one. Yeah.
The only one. In fact, the last 2 Super Bowl winners didn't make the top 10. That's Jalen Hurts and Sam Darnold, which I think is interesting, and I think that's I think that gives hope to a lot of teams in the league, that the fact that you can have a mediocre quarterback and build a really good team around them and win a Super Bowl.
I have a bit of breaking news from the Yaz family. I have a brother, Adam, who's has sung in various bands over the years. He lives in San Francisco.
Yes, you've mentioned him before.
I mentioned him before. Sorry, and he put out an album a couple of years ago.
Yes.
Before the Oakland Raiders game this year in Foxborough, my brother Adam Yaz will be singing the national anthem.
No way!
How about that?
That is unbelievable.
That cool?
That is awesome.
Yep.
Great.
You'll probably be there.
I plan to be there. Absolutely. Will you be there?
Yes, I'll see you there.
Maybe. Are you a big go-to-a-game guy?
Well, I used to be. My parents, the old stadium, my parents had season tickets. And so for many years I went. I've gotten to an age where I really enjoy watching it on TV, I guess.
Yeah, I respect that.
You'll get there someday, maybe, Dennis. But.
Yeah, well, you know what, though? I will say, I'm hardcore, but I joined that GPH room, and I very much enjoy that experience, which is very different from the old Foxborough experience that I kind of grew up on.
What is that thing?
That's the Lighthouse Club.
Oh, okay.
With the buffet meal, the prime rib, and the shrimp.
Oh, yeah. You're protected from the weather.
I have just completely lost my roots, my friend. Completely.
No more dirt parking lot tailgates.
Yeah, sneaking in the back and old Foxborough, none of that. All right, man. Well, I think that's all the time we're going to take today. I want to thank everyone that listened to this entire episode of the Modern Medicine Podcast. I hope you all enjoyed listening as much as we enjoy doing it for you. Find us on Facebook, Instagram, YouTube, wherever you get your podcasts. We are up to about 7,600 followers on the Modern Medicine Podcast Facebook page, which is great. Nice. I'm on a collision course to get to 10K. Please help me out. Throw me a follow, throw me a like, and we will keep producing great content for you. Have a wonderful rest of the summer, everyone. Hope you enjoy it with your friends and family, and we'll catch you in August with another episode of the Modern Medicine Podcast. Be good, everyone.